Hello, and welcome to A Health Podyssey. I'm your host, Alan Weil. The February 2022 issue of Health Affairs focuses entirely on racism and health. It includes papers that trace the long history of racism through to present-day policies and practices that are the reasons for large and sustained health disparities. Now, racism and bias come in many forms, and given the social stigma associated with them, they can be difficult to study. So when a study comes along that provides new empirical data on bias, it makes a major contribution to our understanding of this important topic. One such study in the February issue is the focus of today's Health Podyssey. The study we'll discuss today looks at bias in how patients are characterized by clinicians. History and physical notes are entered into a patient's electronic health record when a patient is admitted to the emergency department as an inpatient or as an outpatient. The notes document the patient's reason for seeking medical care. They summarize the patient's medical, family, and social history, and they can describe the plan to address the patient's medical problems. But what if the way the patient is characterized in these notes is distorted by clinician bias? That's exactly what the research found. Today, I'm speaking with Michael Sun, a third-year medical student at the University of Chicago Pritzker School of Medicine. Sun and colleagues published a paper in the February 2022 issue of Health Affairs examining racial bias in electronic health records and found that Black patients had over 2.5 times the odds of having negative descriptors in their medical records when compared to white patients. Mr. Sun, welcome to the program.
Well, thank you so much for having me. I'm really happy to be here.
This is such an interesting study, and I want to spend a little time going over the findings before we take on some other topics. So let's review the study and its findings. Just frame the major concepts in the research. You looked at the endpoints of negative patient descriptors. What are those? How did you define them? Where were you looking for them?
So, negative patient descriptors are our everyday language, quite normal language that you might find in the medical record, but characterize a patient with in a negative way. So, these are words such as non adherent or aggressive, angry, non compliant, or also defensive. And the full list can be found in our paper. We picked these words because we knew that physicians were using them in literature. So we did a study of, or we did a review of published studies or other editorial writings by physicians, and we picked out these adjectives or these adverbs about, how they're describing patients, and we brought them also to an expert panel for some additional refinement. And then we went into the charts themselves, looked at, how often we were seeing them, whether we were seeing them at all, and we actually did have to edit some of these down, remove a couple words that, weren't actually found in the charts. Again, taking it to that history and physical note. This is really important, the history and physical note part, because when you're admitted into the hospital, this is your first full picture, full summary look at and description of, how the patient is doing, what their history is, why they're coming into the hospital. And it's the note that a lot of people refer to. So that's, the rest of the medical team, the nurses, the physical therapists, anyone else who might be involved in that patient's care. And, quite often, if a patient is coming in for hospitalization and we are able to look back in the medical record, we will refer to the history and physical note of the previous hospitalization. So this is really almost the cornerstone of a lot of their medical care and their narrative throughout their stay in the hospital.
I have to say, I've always found the term non-compliant particularly offensive, as if somehow it's the patient's job to comply with the advice of the physician. But that's just a personal gripe of mine. But it does seem that certain patients might be more likely to be, forgive the term, non-compliant. Maybe they have more complex health needs or difficulty understanding the guidance. You'd want to control for things like that. So how did you go about controlling for variables that might yield these negative descriptions for reasons that don't reflect bias?
So as a whole, we looked at what other known biases exist that we know about in the healthcare system. So other studies have previously shown, and this is whether looking at different health outcomes or treatments, looking at the role of a patient's insurance or their gender identity or their age, and sort of making sure that we knew to the best of our ability that we're accounting for everything that we already know. But then backing it up too, what other factors, as you're mentioning, might be going into something like this? So we wanted to characterize the environment, so the setting of the encounter. We even added the COVID-19 pandemic because of the different, ways in which healthcare practice may have changed during. What we'll call, the before times and, the reality that we have known since. So those were really important because we wanted a nice, very clean look at the effect of race and ethnicity, of the patient's race and ethnicity, and the role of these negative descriptors. I also want to just briefly touch back on, we were using the example of non-compliant, but our study wasn't, primary. It wasn't a primary outcome to look at whether patients were non-compliant or not specifically, but rather, how often are we using this language? I would be very comfortable betting that, most patients are quote unquote non-compliant with their medication at least some of the time. But, that doesn't always get documented. So really we're looking at how often or with what relative frequency were our patients or were different groups of patients being described in any sort of negative manner. Yeah.
That's a really important point because, of course, I've read the paper multiple times, but I tend to think of this as a description of the person's behavior. But what you're really getting at is it's a characterization of the behavior. So, two people may come in and speak in the same tone of voice, but one of them will be called angry, and the other will be called opinion. I don't know, excited or has a strong opinion or something that maybe isn't so negative. And so this isn't sort of an objective, is the person taking the medication, adhering to the treatment plan? It's how does the clinician perceive the person's behavior and how do they write it down when they see it?
Precisely. The way that I sort of liken it is, these versions of truth. It might be true to the person documenting it that this is what happened in the visit, but it is also true that there is additional context behind any one descriptor. So, to your point about angry, what if there's a situation in which the patient was refused care previously, or what if there's a situation in which, the patient's family wasn't allowed to visit, as is so often with our COVID protocols these days, and that will make a patient upset. And whether we afford that patient that additional context is, first of all, a choice per provider. There's no requirement saying you must give the patient's full story, but it also, will then influence how everyone else interprets. So, think about how much more empathetic, someone might be if they had that additional story of this patient, was not allowed to see their family and so, became very upset. That is totally different from just saying this patient was angry.
So what you're getting at is that these are shorthands, and shorthands are an easy place to hide bias. So your study relied upon machine learning. Now, I don't want a graduate seminar on machine learning, but since it really is central to the study, can you just explain to me lightly what that is and how it fits into your work?
So, machine learning is really just a tool, and it's a tool to analyze language in this case. And, we humans, we're actually all very good at analyzing language. So, some of the basic requirements for this program were to say, first of all, let's find the word, and that's a simple Control F kind of thing, where we can just find the instances of this word. But then, is it being used in the right context? So, things like was it sort of looking at this is a resistant bacteria or this is a multi-drug resistant bacteria versus this patient was resistant to conversations about treatment. Those are two totally different contexts. And so we used a manual, we manually labeled a lot of sentences. So we took a few thousand different chart notes and sort of taught the program, this is what these words look like. First of all, this is where you can find them. And then second of all, this is what it means when it's used negatively versus not. And this machine learning algorithm was then able to adapt using this manually inputted sample and then apply it to tens and thousands of notes. So while it does have its own error rate, it does exactly what we tell it to. And it's not something that is I mean, yes, it is very technical, but at the same time, it's something that, all of us are doing on a day-to-day basis. And so it's just a matter of trying to scale that work. So we're not manually reviewing tens of thousands of charts.
Makes sense to me. Okay, so let's jump to the findings. You report a 2.54 ratio of negative descriptors when you compare Black and white patients. Um, just go over those findings with me. And then you earlier said something about how important these notes are. But for those of us who aren't in clinical practice, I think maybe another few words on what this represents if you're a patient and this is in the notes and you may never see them or not be aware they're there, why that ends up being important.
Absolutely. So, as far as the results, so the 2.54 times adjusted odds. So that means that if you're a Black patient in the study's data set, your medical record has a 2.54 chance, a times chance of having one of these negative descriptors compared to a white patient. And this is all things equal. So that means you have the same insurance, you're the same gender, you're the same age, all those things being equal, you still have a 2.54 times greater, odds of having one of these descriptors. And that is quite considerable. And again, we have additional findings. So, having Medicare or Medicaid has an increased odds of having a negative descriptor compared to employer-based or private insurance. And those, like as I've mentioned, can be found in the paper. But this is really important because, as I mentioned, the H&P note is sort of that cornerstone. Sorry, the history and physical note is that cornerstone of patient care, and it tells your full narrative. And I've sort of talked about it a little bit from the patient perspective as far as what happens. But let's consider the role of a consulting physician. So, you're admitted into the general service. You have your primary medical team, but there's an issue, let's say, with your bones. There's a fracture. So they call the orthopedic surgeons. The orthopedic surgeons come by. Before they come by, though, they read this note. And they read this note and it says, oh, this patient was agitated. This patient was, whichever collection of negative descriptors you want to choose. And that leaves an impression that may influence, how much time the orthopedic surgeons, spend with you, or that may influence the demeanor in which they speak with you. And then that also may, somewhat maybe frighteningly, may impact the way that they decide to treat you. A study that we cited by Anna Gadu and colleagues looked at these hypothetical chart notes and surveyed physicians about how likely they were to, or sort of what types of pain treatment plans they would give based off of different notes. And the notes that used more stigmatizing language, physicians were actually less likely to prescribe an aggressive pain treatment plan for that patient with a stigmatizing note. And so, we wonder whether that would happen in this case too with these other negative descriptors. Now, our paper doesn't get into different health outcomes with these negative descriptors, but I think it's an important consideration, and certainly a good future area of study, to know, what types of what are the differences in care that we might be providing based off of our different documentation.
Well, these are really powerful findings. I want to put them in a little bit more context. We'll do that after we take a short break.
Health Affairs Pathways is a new podcast series exploring the various avenues and alleyways of the healthcare system through a variety of storytelling. Unique series are created by fellows at the Health Affairs Podcast Fellowship Program. Join the fellows on their journey to unearth a new healthcare story on such topics as healthcare consolidation, independent primary care, health equity, and more. Our first season is a 6-part series from Lolita Abiancar. Her series, titled Piecemeal, examines how consolidation in healthcare is affecting independent primary care. Subscribe wherever you listen.
And we're back. I'm speaking with Michael Sun about a paper that shows much higher rates of negative patient descriptors for Black patients relative to white patients. Before the break, we went over the findings. I want to put this a little bit more into context now. So you're a third-year medical student. Let's just talk a little bit about how the study even came to be. How does it fit within what you're doing as a student?
I first got the idea for the study in my first year of medical school. We had a required healthcare disparities course. It was actually a lot of the reason why I chose to come to my particular medical school. And we had this lecture by Dr. Monica Vella. And she was describing, this patient encounter with a patient that she has had for a long time, and she sent this patient for a specialty follow up, and this colleague later got back to her and said, this patient didn't really seem to understand. They weren't very engaged in the encounter. It just seemed, that they didn't really, care about, whatever was going on. And she thought that this was really strange because she always knew this patient to be very engaged and very, a true partner in their medical care. And, as I mentioned about the different truths, there were two truths happening. So, one truth is that this physician did indeed have a somewhat, awkward or uncomfortable encounter with this patient. But then the other truth is that, this patient actually has poor medical literacy and had difficulty understanding English and reading instructions in English and participating in that way. And, it really struck me, right? Because, again, there were two truths happening. And, in one way, we could have chalked this patient up to being, quote unquote, non-compliant, as we've, mentioned a couple of times in this conversation already. Or the true context of, this patient, English is not their first language, and we need to provide better care, more intentional care because of that. And I think, back to your comment about the different shorthands that, these descriptors, are sort of that these descriptors are shorthands, is that, how much more useful is it if we say this patient doesn't speak English, needs a translator? How much more useful is that for this patient's future medical care than to say this patient was non-compliant or did not understand or was not motivated? And so, this was happening during my first year. I was blown away by this possibility. So I got in touch with Dr. Monica Peak and Dr. Elizabeth Tung, as well as Tomasz Oliwa at the CRI, or Center for Research Informatics here at the University of Chicago. And together, with their with a true team effort to pull this study off while I was still in medical school.
That's a great story. And is there an expectation out of the program around bias and disparities that there will be a research project, or this just sort of came to you?
Yes and no. So this sort of came to me. I think that there is quite a strong, I think, institutional motivation by a number of faculty and certainly many of my peers to do this sort of research and to do similar work. We also have quite nicely some dedicated time to work on research, so I wasn't, completely left to my own devices in that way, and had a good amount of support for which I'm very grateful.
So after the article was published, you tweeted, "This is what happens when you let poets, writers try to become doctors." I love that. So I am struck by this comment, and I wonder if you could talk about your own views about the link between your poetry, some of which I had the opportunity to read online, and your writing and your research.
Oh my goodness. I didn't know people would really read that tweet. But thank you for, I guess, following my Twitter page. Yeah, so as far as a link, I think that I mentioned about this analysis of language and this attention to language. We all do it, but I think that, my particular background has prepared me to question even what, other people might not think is unusual. So as I mentioned, this used to be our professional language on a day-to-day basis, and yet it struck me as odd. And maybe it wouldn't strike other people as odd, but to me, I very quickly thought, what do they really mean by that? What else? What other story? What other context are we missing here? And so I think, in one way, in a formal way, that has certainly influenced it. I was a first year medical student at the time, so I had not even entered the hospital really at this point of, this the seed of my project. And I think also that had a major role as far as pursuing this project. As I mentioned, there are language norms that these were just part of our normal language in the healthcare world. As someone who was new to it, or at least not quite in the healthcare, not a healthcare provider yet, I had, the maybe naivety, or at least, the untrained eye to say, why are we saying it this way? Why don't we do things differently? And I think there's a huge advantage to being, new to so much in medical practice, that we can start pointing out patterns or things that, strike us as odd, strike us as, where are our norms harmful? Where might our norms be hiding bias?
That's a really outstanding point. One study never changes the world, but it adds to a body of knowledge. And in this instance, I think you struck a nerve among people who've observed this sort of behavior, but didn't quite know how we could quantify it or fully understand it. So, what do you hope comes from this? What's the next question to answer? What's the next change in practice? Sort of where does this take you?
If I may tell a brief story, so as I mentioned, I'm a medical student, and this past year was actually my first year in the clinical space, working in the hospital. And I remember after a particular patient encounter, I sat down to write my note. I was typing it up, and one of the first sentences which they asked, just described how the encounter was in general. And the first word that popped up in my mind was actually difficult. It was a difficult encounter. It certainly wasn't, all smiles and congratulations or whatnot. This patient was sick, and for many reasons, I thought to use the word difficult. It shocked me. I was really frustrated at myself. I was surprised. I was worried that everything that I had just done, the years of research that went into this paper, um, and here I was using that same language. The difference, of course, being that I didn't actually use that word, and I realized if I were to take stock and if I were to afford myself a little bit more time to think about, why I wanted to use this word, I could detail the many other factors. We're in a pandemic, and this patient didn't have family to visit. That they were extremely uncomfortable, in fact, in a severe amount of pain. And here they are in the hospital where they feel like no one's really paying attention to them, and they didn't feel like things were communicated clearly. And those are all opportunities for intervention. Those are understandable things that we can address. So I think that, people hearing this, I hope that they have a moment like I did, that we go to, we might think this one word to describe a patient, that's shortcut. But if you were to afford this patient 10 more words, 20 more words, at least, an additional sentence of saying, what other context is going on, that we might be able to afford a little bit more compassionate and empathetic care. So that's takeaway number one. Takeaway number two, I do want some bigger changes. I would love for our education of note writing to be different. So other medical students, I hope that, if we're able to build good practices before we enter the hospital, even people who are using this language more frequently, biased or not, won't be able to as strongly influence, the good practices that we set up first. And then lastly, I hope that other stakeholders, whether hospital leadership, academic leadership, or other policymakers, really see this as first of all, quantitative proof that bias is a real issue and in our healthcare systems, and that we need to take multiple interventions at different levels to make real change. So, we discussed in our paper things like bias training and additional education as far as our language to describe our patients. Those of course are very important, and unfortunately though, almost a symptom level intervention, and we really need to continue to address the underlying factors in our society that cause bias to emerge. And another thing that we touch on in our paper is the circumstances that prompt bias to occur. There's been work done that increased stress, burnout, etc., prompts resident physicians to use more shortcuts, mental shortcuts, otherwise known as stereotypes. So if we are not addressing all of the issues that are really plaguing our healthcare system with vigor and with the seriousness that it deserves, we'll not be rid of the bias that we're seeing in our notes.
Those are all really interesting ideas. And as we bring our conversation to a close, I just am curious that the inspiration for this came in your first year, as you mentioned a little while ago. You've had some time and experience since then. If you had the time and the inclination to do a follow-up, what would be next in terms of research for you?
I think we touch on this in our limitations a little bit, and I think first and foremost, broader populations. We did this at a single academic center. Can we see these results in other academic centers with different patient populations? And with that, we hope to have expanded information on variables. So, especially as this was my first research project, I didn't really see what was possible or impossible as far as our data collection. We used electronic health record data, and what is present in that data is actually not always the best. So, for example, we were very limited and had to use patient sex, not gender identity, but patient sex, because that's what we record. That's the question that we ask. So, how can we expand to include and be more inclusive of different patient identities? A personal loss to me as someone who's Asian American, we weren't able to characterize, Asian American as its own race and ethnicity group. And instead we're resorted so often, as many research studies are, to characterize many, many different race and ethnicities. So that's all part of it as well. As I mentioned earlier, we'd be really interested in looking at outcomes. So, are there different health or medical outcomes of patients that are impacted by negative descriptors? And then, lastly, it's a question that's actually come up quite a bit: is which negative descriptors, or who's being described how? And that's something else that we'd like to refine in our algorithm, be able to really pull out which negative descriptors are being used the most.
Well, I hope the robust findings you have here create a pathway for you and others to answer some of those questions, because as you note, there are limitations, but there are limitations that can be overcome with larger data sets and additional analysis. And I look forward to seeing the results of some of those. Mr. Sun, thank you so much for your work on the paper, for this interesting conversation. I wish you all the best in your studies, and thank you for being my guest on Health Podyssey.
Well, thank you, Alan. Thank you very much.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about a Health Podyssey.
Health Podyssey is produced by Health Affairs, the leading journal for health policy research. The team behind the show includes Patty Sweet, Jeff Byers, Julia Vivolo, Sarah Kolk, and Sue Ducat. Like the show? Subscribe to a Health Podyssey on Apple Podcast, Spotify, Stitcher, Google, or wherever you listen to your favorite podcasts. Thanks for listening, and have a great morning, day, or evening.